It's 12:30, so we might get started. Tēnā koutou katoa. Welcome everyone to our Professional Forum webinar. We haven't been having them regularly, but we hope to continue having them every month from here on. And welcome to our colleagues from outside of Te Whatu Ora, if there are others there. And today we have Jen Gower. She's going to be talking about ward quality and safety walkabouts. Jen's a nurse consultant in the Quality and Performance Improvement Southern team. And these walkabouts have been happening for about 6 months in our wards, and they're very exciting. And they're starting, I think, to gain more and more traction now as people become used to them. They're a great interprofessional way of looking at quality and safety in our hospital. And so I'll hand over to you, Jen, and let you continue. Thank you very much. Welcome, everyone.
Thanks, Lorraine. So welcome to you all, and thanks for joining me to hear me talk a wee bit about the experience that we've had here in the Quality and Safety Walkabouts. Just to give you the heads up, not only am I in a shared office and wearing a mask, we've now just had scaffolders appear this morning, so the scaffolding being constructed outside the window, so apologies if there's some background noise. So I think questions into the chat would be great, and then we'll go through those at the end of the presentation. Okay. So hopefully the screen is sharing. Yes, I can see that. Okay, so we'll start just to give you a little bit of an overview around what I'm going to talk through today. So just really from the start, where we got the idea around it and recognising the need through the whole process of engaging with key stakeholders, getting input from the right people, look through some practical examples, and then the key learnings and where we are so far. So I've said 6 months, or a wee bit over that, but I'll go through the process with you and explain the journey along the way. So I suppose it was probably around this time last year, and there started to get a little bit of interest around our data. You know, we were seeing data both internal that was self-reported through Safety First, and also the Health Roundtable and external data that was showing that really our patient harm wasn't getting any better. In fact, in some instances was getting worse. There was interest not only from clinical teams, but also from the board. So we sat down with Chief Nurse, Allied Health, Clinical Council, and came up with an idea really that we probably needed to have a walkabout at local level. So communicated with charge nurses, which my background, obviously I'm a nurse and predominantly was with the nursing teams. Later, involvement with Allied Health has been really good, but in the first instance this was to do with the ward activities. So we did a couple of workshops on the Dunedin site in Southland, so Queenstown Lakes were involved as well, so we had representation from the 3 main sites. So you can't read this, but I have themed it, and we'll go through that in the next couple of slides. But it was quite an interactive workshop, really just to get an understanding of where people thought they were at, what their biggest concerns were, how did their team understand what their biggest concerns were, and what were they doing about it, where did they get the data from. And really it was everything they needed to be able to talk about quality and safety in their area and identify improvement. So I tidied up the post-its and popped them together into some themed information. So we really looked at what the biggest concerns were, and staff, not surprisingly, I guess, it was around pressure injuries, falls, medication, discharge planning, and nutrition. There were some other things that were mentioned as well. So we had infections, we had some of the safe staffing issues as well. So we were predominantly trying to focus on the patient experience. So how did staff also find out? So of course, what tends to happen is that people in more senior leadership roles get this information, but actually the key people who can make a difference, so the clinical staff hands-on, maybe don't find out about it. So we set to understand how that information was shared. And in some instances, it was emails or staff meetings. Well, it really needed to be a little bit more timely than that. So we then talked about how we can engage and make it a really good interprofessional approach. So we had some good ideas around that, who needed to be involved. And I guess it did also depend on the focus. There will be certain allied health team members who needed to come in depending on what the focus was. So when it was medication, there were certain staff, but not everybody. So we needed to think closely around that. And then the majority of people felt that it should occur weekly when we talked about frequency. So we were getting a bit of a theme together, who needed to be involved, the frequency. And then one last question that we asked was, would it be useful if we themed the focus so that everybody in the organisation was looking at the same issue? And for certain people, it would be less of a concern than it would in other areas, but we felt that actually if that was the case, then maybe people could focus on something else for that duration. But unanimously, people felt that actually working on it together as an organisation, there was certainly a benefit to that. So I guess when you're looking at anything that needs improvement or anything where we've got a risk, there's data involved, and accessing data is not always that easy. The other thing as well is that if your data looks good, then we over rely on it, and if it looks bad, then we refute whether it's actually accurate and we don't maybe trust it. So we needed really to make sure that the story with data was accurate and that people understood what was going on. So we needed to work out, what do we need to make better, what do we need to reduce from happening, but overall we needed to get the right people involved. So it was around these conversations, and that was the ultimate goal really. And I'll talk a little bit more using pressure injuries as an example, how we did a deep dive when we looked at the data. It's about not taking it at surface value, it's about starting a conversation and then making sure that it's accurate so we can trust it. And if people are making an effort to to make changes happen, then they really need to see that there's been a benefit to that. So it was about ensuring that that data was visible for them. So within the organisation, when it comes to patient safety data, we've got two sources. So we've got self-reported, so the staff have to acknowledge that there's a risk and that something has either happened or was a near miss. And then also we've got coded data. So our safety first dashboard is the self-reported. So this obviously, as it says, relies on people recognising harm or a near miss occurred and putting that data in. So these are all the categories that can be reported on. And then what happens is that there's been dashboards created. So it gives an organisational perspective. And then depending on where the individual works, they have a scope view. So if you're working on a specific ward, you will see the detailed information for that ward. So that's really good. That gives you an idea of what's being reported in your area. It is only half the picture because the other side is the coded data. So this comes from what's written in the notes, the code that the coders assigned to it, and then that's submitted as part of the national data set to the Ministry of Health. The problem with that is there's always a huge lag. There's normally about 3 or 4 months. So we set up to create something locally, and this was put together by the IT and the data specialists, and this focused on the key concerns that we'd identified. So this allowed staff to get basically they would get this information as soon as the notes had been coded. So once they'd been completed, sent to the coders, a code had been assigned, we could start to see this populated. So maybe 3 weeks. So that was much better to see whether any interventions were making a difference. And then each of these can be drilled down. So that's an example there, looking at delirium. So you can see, and that can actually be drilled down to patient level so the staff can find out more information. So we were getting there with it. We knew who needed to be involved. We knew how we wanted it to happen. So we just really needed to start the ball rolling. So the idea was from the start of this year, we could get these up and running and get key people involved. So the schedule was decided. So the IPC, although it didn't feature too highly because of the current climate with COVID, we really wanted to make sure that people were prepared from an IPC point of view with regards to PPE training, and everything else that was associated with preventative measures around IPC. So the focus was more around that prevention, I suppose, rather than actually some of the other elements that we would have generally looked at. And it was quite a good one really to start people off with because they could see the absolute relevance to it. So we then, a couple of months for each one, as we decided by the clinical team. So we did IPC. We then looked at pressure injuries for March and April, falls in May and June. We had a month off in July. We thought that a couple of months in the year would be really good to just consolidate and let staff just do a bit of a check on where they were up to. And then the previous ones they'd covered, just have a wee bit more time on them. And then our current focus is delirium. So key to anything like this is to get some posters out there, is to, you know, get the comms and publicize it. So we sent some standard ones, pop these up around the wards, and then the staff were encouraged to create their own, which would advertise the day that they decided and the time, and it was roughly thought to be about 30 minutes. So although not prescriptive by any means, this was quite a big undertaking, really. You know, we were getting staff to do something that they weren't used to doing, really. We were getting them to try and get out there and lead the team on these quality and safety walkabouts. So we just thought a single page might be quite helpful. We really didn't want it to feel as though it was very ritualistic, as though it was prescriptive, as I say, but the idea was to give them some confidence, some conversation starters. But I suppose what we were really keen to ensure was that if people didn't attend, they benefited from the discussion. So it wasn't around the 3, 4, 7, 8, 9 people that went on it. It was around what was decided from that would be good for the team to learn from. So we're all really good at making notes and popping them somewhere, but actually what we needed to do was to make sure that good discussions that had happened came to fruition. So any actions that were decided. So we just put together a couple of pages. So the top one was around things that needed to be focused on for that next week. And really no more than 2. Picking up 2, I think, is good. Anything more than that, you risk not managing to do it or just overwhelming the teams. And then the central one was if anything good had happened that you thought other people may benefit from. So again, a couple of those. And then the bottom one was just a single line or just an action tracker, so that if, say I went along to one of the ward areas and I've not been for maybe 4 weeks, they could tell me things that had been going on, regardless who was running it. Because the whole idea, again, is there were many people, it was felt, it didn't have to be the charge nurse. And that I probably should have mentioned came from the workshop. It was felt that there were a number of people that could actually lead them, didn't have to be down to the charge nurse. So this looks busy, you're not going to be able to read it, but what I'm pointing out here really is that when we came together with the walkabout design, they naturally followed themes, really. I'm going to use delirium to give you a better example and to talk through it in a bit more detail. But when we sat down with the IPC team and we got all of the information, so my job in this is to theme the information that comes from the experts. So what I do is I spend some time catching up with people who are really knowledgeable in whatever area we're focusing on and get their feedback and their suggestions. You know, what does good look like? What do we need to check that people know about? What do we need to orientate them to? And we basically had this big list. So when I themed it with IPC, it's worked really well for subsequent ones, actually. So we've got the who needs to be involved, which again will vary depending on the focus. We need to understand the data, as I talked about before. We then need to have some staff training and resources, and the same for patients. And then the central bit is when we're out and about, what do we look at? Because the whole idea with this is that although some time will need to be spent at the board, is that people are out there looking, talking to patients, looking at the environment and thinking about, you know, how can we make an improvement in our current focus. So historically we had what we called Gemba walks, where you get your executive, your leaders who normally spend time in an office, so they come down to the actual place where the work happens, and that's what the Gemba was about. The problem with that, it was felt very much that it was owned by that team. It wasn't owned locally, so what we would have was almost a degree of fear, I guess, in the clinical teams. Everything had to be updated, they were going to be checked on, and we really didn't want that. So this was a completely different approach. It was owned locally, and people can come along, you know, the execs are invited, the leaders are invited from both the clinical point of view and management, but it's definitely directed and focused by the clinical teams. So again, what came out of these was that there were themes within it. So I'm not going to go through this in detail, obviously, but what I wanted to point out is that within that, what appears to be a busy guide, which is printed on A3 and popped up on the board with the other information relevant to the focus, is that we realised that there were themes within it. So you could have a staff focus, which again is going to be mainly around their training and how confident they are and what can we do to improve that. So the blue text is hyperlinks to our Midas documents or to websites so that staff can learn a little bit more about it. There was also quite clear preventative strategies within that. So, you know, do we have standardized approaches? How do we recognize at-risk patients or situations? And then making sure that we get the correct interventions in place. So the idea with theming them is that 1 week they may say, oh, for this week's walkabout, we're going to look at the staff side of things. So where are we at with X, Y, and Z? And for this week, we're going to look at preventative strategies, and we may go back and revisit this. And then for the next week, well, we've got data and things happen. So how do we investigate it? How do we learn from it? And how do we share that information? So it was really so that people didn't have that guide and think, geez, you know, where on earth do I start? So we also looked at the environment and equipment because we found that that was really important as well. So we wanted to look at some of the more practical aspects as well, including signage, posters available, any little prompts that we can put in place that will be really good. And then maybe looking at the visiting hours, you know, for a patient with delirium, having some flexible visiting hours is really good. We want to get far now in with them as much as we can because we know that that does work well. So it was just looking at different aspects to do with the ward in this side of things. And then the final one is, of course, the patient and whānau. So what are we putting in place for them? So again, visiting hours. And also maybe this was a really good idea that came from one of the areas, is that there are certain high risk elective procedures, or there are certain elective procedures with a high risk of a delirium happening afterwards. So do we need to look at educating patients and raising awareness that it might be something that happens before? So with each of these walkabouts, it was really key once they'd done some fantastic work that they didn't just forget about it. So it was that sustainability side of things as well. So for each of the guides, this is just a single page, nothing fancy, staff just write on it, key improvements that they've made and the sustainability focus that they want to have going forward, because the concern that we had was once the 2-month period had ended and we moved on to something new, was there a risk that staff would just think the box has been ticked, we've covered it, and then not continue to look at that? So the idea is that this is just left up on the staff board next to the specific walkabout so that people can see and staff can see as well in that area what they're looking at. So I'm just going to talk through pressure injury in a little bit more detail because we've had quite a bit of experience and output from this particular focus. So as I say, most things start with data. So this was one of the things that was particularly alarming to the board and the execs, and was flagged as in, you know, you actually need to do something about this. So we got the data, and you can see that this is health round table data. So this is Australasian, and we're benchmarked against other, well, similar hospitals. So you can see we've got the Dunedin data on the left and Southland on the right. So it looks as though Dunedin is actually performing the worst. So this is for the adverse events. So this is the stage 3 pressure injuries, the stage 4, the unstageable, but also interestingly, unspecified are included in this. And the reason is that unspecified could flag a training opportunity. So is there an educational need here for staff? So if you put something down as unspecified, it could be anything. So they really are very keen that it's identified and that we don't use that as a bit of a cop-out. Or I'm not sure what it is, so I'm going to put it. It could be a 1 or it could be a 4. So the idea is that if you do put unspecified, you land in this box as well. So when we drill down with this data, this was exactly what was happening. So although the numbers are much different, you can see that the highest number lands in the unspecified. The actual stage 3, 4 and unstageable and suspected deep tissue, which are the real nasties, were not that high, but we did have an awful lot of unspecified. So we thought, well, okay, let's look at our internal data and let's see what's been reported. And then we realised there's quite a difference, because actually when you go into safety first, the staff have to say what it is. So they can't put unspecified. So if they elect to report a pressure injury, they're pinned down, they have to say what it is. So we then got a selection of notes who they'd had a pressure injury, entered onto safety first, and we pull those same notes so that we could see, well, okay, what are they writing? Because it's what's written gets coded, and the coded comes back with this unspecified. So it was all kind of fitting together, really. So out of those 50 sets of notes, there was only about 20 that actually had a specific stage. The rest of them were descriptive. So they'd obviously said things like, pressure injury, left thigh, but hadn't said what kind of pressure injury, or red, potential pressure sore, redness on bottom. So all these things that were kind of alluding to the fact it probably was a pressure injury. Interestingly as well, there was also 10 sets of notes that didn't mention the pressure injury. So although they put it onto safety first, so there was starting to be a bit of a theme around maybe education. So we certainly thought we need to understand from a staff point of view a little bit more about their understanding and how they document. So this was just sent out to staff. I think we've got about 42 responses. So did they feel confident? So half of them did. It varies. They came back with as well, and what they felt quite confident with was maybe the stage 1s and 2s. When they started to look a little bit more complex, I guess they were lacking in confidence, and this was obviously a concern around it. So, and then we just thought, have they ever submitted a pressure injury on safety first? And we found that actually more people hadn't than had. So we then wanted to understand whether they did actually write pressure injury in the note. So again, less people did than those that consistently did or didn't. So if they answered no, or sometimes we asked them a little bit more, so why don't you write it? So again, there were themes. They weren't confident. They didn't realise that if it was already in safety first, surely that would suffice. Or I already write pressure injury, I describe it, and I thought that would be enough. So we then threw this in, which was, I suppose, a wee bit left field, and people wondered why on earth we were asking, do you know that clinical coders don't access it? But actually this is why, and I've touched on it with you a little bit, but actually the coders can only code. They translate a clinical statement into a code, and it's that code which then gives us all of that information, and sometimes misinformation, as we were starting to see. So that was quite an interesting exercise with them. And what came out of that bit of information, I guess, was that we did some training. So we did it on Teams. It was recorded so people could watch it at a later date. And I know quite a few educators have used this to do the 30-minute training session with staff. We also, there was a pink sticker already in place, but we modified it a little bit. And this pinned staff down, they had to put down the stage of it, and it gave them a few more prompts around whether it was hospital acquired or community, as in did they present with it. And also that prompt, did they put it onto safety first? We also borrowed a pressure injury education trolley from Essential, who we hire all of the mattresses through. And that was really good. It rotated. It had about a couple of weeks in each ward area. That had some really good resources around staging pressure injuries and just general information. So that had good feedback from staff. So at the end of the 2-month focus, we'd come up with some really good ideas, improvement outcomes, and discussions that had been had. So that's just a list of them, and just pulling a few of them out. The education with staff, as I say, we covered through a couple of ways. We realised that actually we probably didn't have cushions and some of the pieces of equipment that made patients more comfortable and less at risk. Leaflets, we realised it probably needed to be a little bit more handy with distributing those. There was a walk-in bus to get people up and about and relieve pressure. We previous work that had been done when we looked at how many steps patients walked, it was actually really low. It was in some instances less than 100 in a day. just because of steps, just because they didn't really go very far. They went from the bed to the toilet and back to the bed and weren't really encouraged to walk around the ward. So we wanted to try and get people up and about and walking around the place. And then some of the wards came up with their own ward quizzes and chocolates for prizes. So it was just really, as I say, keeping it fairly light, but that education focus. So I guess the ultimate question is, was there any impact? So these are our adverse events, so the 3s and 4s. And what we found was when we introduced them, it dropped down to 0 being reported for a couple of months. And then I guess, as we maybe feared, when the focus switches to something else, we've started to see an increase. And actually we've hit a high of 5 for the past couple of months of stage 3 and 4 pressure injuries being reported. So it certainly has been flagged back to the teams, and maybe they go back to that sustainability focus that I talked about. What did we do that we're not doing anymore? And of course, there may have been other influencing factors. We know that the patients in isolation during the COVID admissions were at a higher risk, but that's for the individual wards to do a wee bit of a deep dive into and look at if they were an area where the patients had these pressure injuries, what happened and what can they learn from it. So without going into as much detail with the falls, I'm just going to show you or share with you a couple of examples of improvements that came out of that. So I think maybe the biggest eye-opener was the patients who fall aren't always the ones that are at risk. So when we do the screening and we have at-risk patients, we put plans in place to mitigate the risk. But actually we did find that patients that fell were sometimes those ready for going home. This was certainly in the rehab areas, and the staff felt it was almost that the patients were trying to prove a point, I am ready to go home, and maybe push themselves a wee bit. But there were also things learned. For example, a patient had got up in the night who wasn't expected to be a risk at all and had leant on the table and pushed the table. So this flagged the need for some patient education. You know, the tables unfortunately have wheels and they will move if you lean on them. Also things like the raised toilet seats are really unsteady if you just push on one arm, and that did lead to a harm in a patient when they fell. So it was just educating patients to put the pressure on both arms as they ease down or up onto the seat. And we really found that the call bell use needed quite a bit of information. So it wasn't just saying to the patient, here's the call bell. It was actually making sure that they were prompted to how the button was pressed, reassured that they did need to call staff. And then other things that we put in place was like, you know, making sure there was a clutter-free side of the bed, and the same with the corridor. We tested night lights because we realised that some of the night lights weren't working, and then looked at things like the safe working limits for moving patients. Staff weren't necessarily aware that there was weight limits for that, and some staff training issues around equipment. The deconditioning was quite a big one as well. So again, we found that all of the idea is with the walkabouts is that they do start to overlap. So we were finding from the pressure injury, when we looked at deconditioning and getting up and walking, is that we needed to encourage that as well as part of the falls. And then just at the bottom, we've got the post-fall huddle, which I'll talk through in the next slide. But this was the posters that we put together for the call, don't fall. And what we did, these are placed on the walls, but importantly for the patients who we felt were a key risk, is they're just laminated and they're on the patient's table, so that they are prompted each time, don't, you know, mustn't get up, I need to make sure that I use this. And then there's an audit tool that's just on the left. And these came out of pretty much the key themes that we identified. So looking at the environment and things that were in place, but then also just visiting 5 patient bedsides and just looking and talking to patients around some of the aspects. So the post-fall huddle, we've tested this in a couple of areas. It's had really good feedback. So Southend Rehab and Surgical Ward in Dunedin, positive feedback. So the idea around this is that as close as you can to when the fall occurred, when you look into literature, it's almost described as like a crime scene where you try not to touch anything. You get key people involved and you make some observations. So the left-hand image just steps you through the process, and then you've got a double-sided post-fall huddle, which is completed, the 2 documents on the right-hand side. And the idea, it's not a checklist. We didn't want people to go through and put, did they have the call bell? Yes. Was the lighting good? Yes. It was to generate discussion, so there's some prompts there. And the idea was to try and learn from it to get the staff experience, but also the patient and whānau side of things as well. So that's had really good feedback, because what very often happens is the charge nurse is responsible for completing this. Maybe if the notes aren't as comprehensive as they could be, it leaves a real gap and they can't get that accurate information. But it also means that when we talked with people who are key to falls and trying to prevent them, so some of the allied health teams, they rarely get tasked with it, and the charge nurse does this. They try and go through the notes and get all of the information together without troubling other people, and also to try and, I suppose, expedite the process. But in doing so, we lose that critical insight and input from other key people. So the idea with this is that everybody comes together, and we have had the charge nurses from those areas say how beneficial these have been when completing the reports. And also there was an ACC that was for one of the patients, and they were able to get some accurate information from this to help expedite the process with that. So I suppose we've got to the stage where we really want to try and understand the overall experience to date. And although I'm presenting this now, we are in the throes of getting feedback from staff. So we've definitely not completed. It's open for another week or so. And what I've done is I was going around originally just asking people to complete this survey that we've put onto Microsoft Forms, but I've shared the link with professional leads and nursing leadership, just to try and get an understanding of from their teams how they're finding them. So far, it looks the majority of people have been the nurses on the ward that have completed it. I've not got every question here because it wasn't really worth going through it because we're still in this stage, but we're definitely picking up some themes. So for example, they should be weekly, but when we've talked to staff, it looks as though they're possibly not weekly. And that might be going back. I do know that in some instances, if the charge nurse isn't around, we've still got a bit of a reliance that if they are not around, then it can't happen. But if you look on the top right, do you feel aware of how this ward performs with patient harm? We're certainly getting there with that, and that's definitely an improvement of staff not being aware to start with. Bottom left, is there an organisational approach? Well, obviously, this would be to focus on the walkabouts. More people are aware of that than aren't, so again, that's promising. We probably just need to do a little bit more work on getting the data up and displayed, and that maybe goes back to the more senior nurses and allied health, etc., being aware of it, but possibly not displaying it on the board. So just a wee bit of work needs to be done around that. So I guess the themes and the overall key bits of information that's come out of it is to make sure that we don't overthink it. The idea about this is to get staff out and just start talking patient safety and what needs to happen to improve it. It does need to be weekly. If we start to leave it longer than that, we either miss the opportunity to follow up on actions, or the staff start to, they think it's due to happen and it doesn't. So we lose a wee bit of credibility. The data is really important. So we need to make a slightly better effort at getting that up and displayed. And again, I'm making generalizations. There's some wards that do a really good job of this, but what we really want is to make sure that it's standardized and it's happening around the place. As I said, key is to get that feedback to people. So make sure that if they're not able to attend, is that staff are aware of actions from the walkabout and that's shared and is visible with them. Follow up on actions similarly. And then there's been also some really, really good pieces of work that's happened. So they need to celebrate these achievements. And I'll show you in a second, we've got a central Teams walkabout site where people are encouraged to do this. I think what people are realising as well is that the idea with the walkabouts is they're almost pieces of a jigsaw that are coming together. So there is a big overlap. And when we've got all of these measures in place, we should provide that safer journey for the patient. So we will see things that are starting to overlap, making it easier. We need to make sure that there's some good signage. Again, we're lacking with that. We've got that general these are happening, but the specific areas, you know, one ward may have it at 2 o'clock on a Tuesday, another ward 10 a.m. on a Friday. And if we've got colleagues that aren't based on the ward all of the time, they need to know when they happen, because they may cover a few wards. So we really need to get a bit better at that. Local leadership makes a huge difference, as I say, but key to it, I think, is that sustainability. We absolutely need to make sure that once we've covered something, it doesn't get forgotten. So there's lots of small pieces of work that can make a difference. So what we are emphasising is to focus on the aspects that we can control. So what pieces of work can we directly control, and the big things that aren't able to happen from the ward level itself, then we'll maybe look at that at a later date. But it's those small pieces of work and improvement that can make it much better overall for the patient. So as I said, when we inquired with people around the best way to communicate, we thought we don't really want emails because everything will be lost. So we've got a Walkabout team site. So everything is in that. We've got these different channels that you can see. We've got a general one, and then for each of the specific focus that we've had so far, and they all follow a similar theme. So we've got articles in there, we've got posters, we've got staff resources. We have a monthly check-in, which our Chief Nurse and Midwifery Officer, Jane Wilson, leads and talks to staff on teams just to see what their experiences are. We do have an evaluation at the end of the walkabout, and we start to present some of the key findings, but again, that is ongoing. And then what we've done more recently is to share the invite when the teams have identified that they will have the walkabout. That's gone out to the wider team to invite, as I say, some leadership and some executive team members, so that they can be invited and they can come along and see what the wards are doing and what systems they've got in place. Okay, so that's me finished. So I shall check, shall stop sharing and then have a look if there's any questions.
I should have said earlier, if anyone has any questions, they can go into the chat function or the question and answer function there. If anyone has anything for Jen, we can wait briefly. That was amazing, Jen. I really enjoyed that. It just shows what can be done when a focus, a safety and quality lens is put onto one particular area. Falls, pressure injuries, delirium at the moment, and how much can come from that. And someone said, thank you, Jen. Sorry, I don't know, I don't know identifiable names, so thanks, Jen, is from someone, which is nice. And there is another one. No, that's the same one. Sorry. Yeah, I mean, I remember you starting this at the beginning of the year, you and your team, and talking about it. And when you actually see it, it's like a really good summary of what you've done over the last 8-9 months.
Yeah, they've achieved heaps. And I think, you know, as I say, what we really probably need to encourage a bit better is how they